Imagine this is your grandma and that she has been living with an implanted pacemaker for 12 years. Unfortunately, the wire leads that connect the pacemaker to her heart have become infected, so now she must go through a risky procedure to detach the leads from her heart tissue and pull them out of her chest. Sounds scary, right? Well, this procedure is called lead extraction, and it is within the clinical problem that our capstone team innovated this semester.
To introduce ourselves, we are Team Lead X, and our names are Harpole, Malia Yuhl, Ramon Grullon, Nicole Frey, and Alejandro Vasquez. For this project, we also partnered with 3 clinical mentors from the Mayo Clinic, whose names are Dr. Kella, Dr. Elsa Ba, and Dr. Ali.
To provide more background on the problem space, a CIED, or cardiac implantable electronic device, such as a pacemaker, is a medical device that sends electrical signals to the chambers of the heart in order to regulate the heartbeat to a normal cadence. This device has 2 key components. One is the implanted pulse generator, or where the electrical signals originate from, and the other components are the wire leads that carry the electrical signals from the pulse generator to the targeted heart tissue. The most common indications for lead extraction are infection and malfunction. Numbers-wise, there are 3 million patients with a CIED in the U.S., and lead extraction has a serviceable, addressable market of $520 million, so there is a large incentive for an established procedure to remove these faulty leads. Today, a typical extraction procedure begins with excising at the pocket where the generator sits under the skin and detaching the leads from the full pulse generator. To help the physician pull the leads back out of the vessels, a sheath, which is a hollow tube, is typically slid over the lead until reaching the distal end, or where the lead is implanted at the heart tissue. The physician then engages in what's called traction and countertraction, or pulling on the lead while simultaneously pushing the sheath into the heart tissue to dislodge the lead tip. The leads are then pulled back through the subclavian vein and the procedure is complete. When leads have been implanted for many years, the body's natural immune response is to deposit a layer of fibrous scar tissue along the foreign object. However, sometimes this layer of tissue becomes so thick that it physically embeds the cardiac lead within the vessel walls of the heart. When this happens, the extractor can no longer just pull the lead out of the heart. Instead, they must utilize a powered extraction sheath able to cut away at those tissue deposits to free the lead from the vasculature. Currently, there are 2 devices that can achieve this goal. The first is a mechanical sheath that cuts away tissue with sharp rotating blades. The second device is a laser sheath that destroys tissue by heating and bursting the cellular contents. However, both of these devices have unfortunate shortcomings. Because the mechanical sheath is a manual device, the operator can easily exhaust their hand pulling the trigger over and over again to rotate the blades. Additionally, the procedure itself takes longer since device efficacy depends on manual activation and is not automated. For the laser, it easily cuts through fibrous scar tissue, but it is not able to destroy harder calcified tissue, which sometimes appears along the lead body. If the operator encounters this problem, they have to switch out the laser sheath for the mechanical sheath, thereby spending more money and lengthening procedure time. Additionally, this device has been described as a, quote, hot knife through butter, end quote, and that there is not a lot of tactile feedback for the operator to determine if they're cutting through the right areas. For both of these devices, a big concern is their potential to inadvertently cut through the vessel wall instead of the fibrotic tissue stuck on the lead. If this happens, within these major vessels of the heart, it can result in the patient bleeding out within minutes. Right now, there is not a reliable way for physicians to determine whether they may accidentally cut or push the sheath and puncture vessel wall as they advance the sheaths over the lead. It is heavily dependent on extensive training and the physician building up experience with the feel of how much they should be simultaneously pushing and pulling. Serious complications like this occur in as high as 10% of lead extraction cases, and is why many people opt out of this procedure altogether. Specifically, of the 74,000 individuals eligible for lead extraction each year, about 84% of them elect not to have it. Thus, there is a clear need for the development of a new extraction method that addresses the shortcomings of current devices. This is where our team, Lead X, comes in. We have developed a new lead extraction sheath. This device can effectively cut through tissue to remove the leads, is more ergonomic for the user, and most importantly, is a safer alternative to what already exists. We are excited to reveal the specific device components at Expo on December 4th.